No, everybody.
No, say it here, Mary.
All right. We have on the agenda House File 2676. This is Public Health Response Contingency Account Bill. MDH is going to give a short presentation on the recent infectious disease outbreaks, not just measles, but others as well. So why don't we move to the testifiers. Mr. Pollak's here from the department. Do you want to walk through your presentation?
Thank you, Mr. Chair. Dan Pollack, Deputy Commissioner for MDH. I'll do a little piece and then I'll let Chris do some background, and I'll be the closer as well. I want to thank you, Mr. Chair, and your staff for working on this issue. Obviously, it's late in session. There's a lot of other things happening at the Capitol right now. But most of you have seen the news, and we are currently responding to 3 serious different disease outbreaks that realistically are going to require some additional resources to contain. So Chris is going to give a overview of the current outbreaks, and then I'll talk a little bit about the contingency account idea.
All right. Welcome to the committee. Please introduce yourself and proceed.
Sure. My name is Chris Ayersman, and I'm the Director for Infectious Disease at the Minnesota Department of Health. And I'm just going to give you an overview of what we're dealing with right now. I think measles has probably been in the news quite a bit and caught your attention. We currently have 64 measles cases identified in Minnesota. This is the largest outbreak we've seen in nearly 30 years. And by comparison, last year in the United States, there were only 70 cases. What we're seeing is susceptible, unvaccinated individuals. And so of those 64 cases, 61 are unvaccinated. And when you think about 64 cases, it's important to keep in mind that we're not just dealing with those cases, we're dealing with the 7,000 people who've been exposed. And we follow up on each of those exposure situations to ensure that those individuals know about their status. If they're susceptible, like if it's a child who's not vaccinated, we recommend that they not attend child care. If it's a healthcare setting, there are a number of things that need to happen. So as you're thinking about the work and as we're describing the challenges, keep in mind that the 64 cases represent 7,000 exposures. And this outbreak has been going on since April 11th. The first cases were reported to us then, so we're just beginning our 6th week. And we've had staff working every single weekend for the past 5 weekends and then working into the evening. The next outbreak that we're dealing with is multi-drug resistant tuberculosis. And typically at the department, we see 1 to 2 cases of multi-drug resistant TB each year. As you may be aware, we see anywhere from 150 to 200 cases of tuberculosis every year. And multi-drug resistant disease is TB that is actually resistant to at least 2 of the drugs that would be used to treat it. So that means that the treatment involves what we call second-line drugs. They're harsher. They require longer therapy. So certainly we want to prevent multi-drug resistant TB from occurring, and we also want to make sure that we don't see a lot of cases. So with the cases that we've seen this year, we've had between 2016 and 2017, we've had 9 cases of multi-drug resistant TB. They've been in the Hmong community and mainly in elders in that community. And our concern is that this is a very serious disease, and because of the cultural, communal, multi-generational living situation within these families, we have the potential to have spread to children as well as adults in their middle years. And recognizing how serious this was, we did invite CDC to come in late February and early March to provide some expert technical assistance to us. And again, we're talking about 9 cases of multi-drug resistant disease, but we are just in the process of screening 250 individuals who were potentially exposed to some of those cases. So again, the cases don't reflect all of the work that's required to contain the outbreak. And then syphilis is the other concern that we're dealing with. And syphilis can obviously cause a number of serious consequences, but what we're most concerned about recently is the potential for congenital syphilis. we've seen an increase in syphilis over the last number of years, but between 2015 and 2016, we had a 30% increase in syphilis cases, as well as typically we don't see any or perhaps just one congenital syphilis case. We went from 2 congenital syphilis cases in 2015, which we thought was bad, to 6 in 2016. So our concern is that we're seeing an increase in syphilis. So last year we had 852 cases. This year we've had 264 already. And those cases are occurring more frequently in women. And the reason that that's a concern is because if they're of childbearing age, they have the potential for transmission to their unborn baby. And in addition to the general increase in syphilis, we have also seen outbreaks in American Indians. And so we have an outbreak currently that's ongoing with 37 cases in Mille Lacs County. And so that is a concern to us as well. And just to identify that this is, more than our usual workload, because obviously in my division we do infectious disease work every single day. We have over 70 staff who are working on our measles response, and as I mentioned, they've worked evenings and weekends for the last 5 weeks. We have 22 staff who are dedicated to working on the syphilis response. As part of that, we had 4 outreach sessions in Mille Lacs and offered testing for syphilis, for hepatitis C. We did pregnancy testing. We had syringes available, and that's the kind of thing that needs to continue if we're going to be able to get ahead of the outbreak. And then in terms of the TB response, we currently have 15 staff working on that, although we anticipate in the next week or so we're going to have to ramp that up as well. So that just gives you, and I realize we don't want to make you be here late into the evening, but that just gives you a sense of the type of intensity of work that's occurring. And in addition to what's happening at the state health department, our local public health partners are all also partnering with us. So with measles, Hennepin County has had 50 staff that have been working on measles for the last 5 weeks. Crow Wing County, LeSueur County, and Ramsey County have been involved with measles. And then, as I mentioned, with the TB, St. Paul Ramsey County Public Health is involved, and with syphilis, it's multiple counties, but it's also the Mille Lacs band of Ojibwe that are working with us on that. So it's not just the efforts that the state health department are putting in, but it's also our partners in local public health.
And Mr. Chair, I'll just conclude with that we appreciate the contingency fund proposal. Obviously, we've done something similar like that for natural disasters in Minnesota. $5 million is probably about the right amount of money where we're sitting today. We think we've incurred costs of about $2.7 million for the 3 outbreaks thus far. That actually already exceeds our general fund appropriation in this area. Right now, we're basically diverting people off of their federally funded activity to do the response. The bill that is in front of the committee does have an LAC review process and fairly detailed notification requirement, so there still would be fairly extensive legislative involvement and oversight in how we use every dollar coming out of this fund. So happy to answer questions and discuss the need.
Thanks, Mr. Pollack. And I would just direct members to the packet. We're not going to act on the bill or move it or the amendment, but just want to bring it up for discussion. And the amendment is clarification on a couple of things. But the first is just to figure out what an emergency is and define that, and so that when an outbreak occurs that we can kind of define that and put it into its own category. And although it doesn't seem like it, we're not here most of the time, and if that should happen when the legislature is not in session, how we do that, how we deal with that. The LAC is a way for this to become funded, for the money to get approved and moved through without the legislature needing to be back in session, and the authorizing entity to be able to do that. The amendment just does a little bit of clarification. It provides that MDH must provide written notice to the chairs and ranking minority members of the HHS committees with the information. In the event requiring the public health response, the public, where the public may be required, and estimates the staff hours and resources that the commissioner may need to divert to provide to that response. So what we're trying to do is figure out where the line is for an outbreak and emergency response that would require this, and to have oversight of the funds, approval of the funds, whether or not we're in session, kind of mimicking some of Representative Pulowski's look at with bonding in terms of being able to avoid a special session in case of a disaster. And because of the kind of emergent nature of this, came later in the session, so we appreciate the department's help in putting some language together in a way that I think is kind of a common sense way to respond to this. So that's kind of an explanation of the bill and the amendment and kind of how we got to where we are. We've got the department here to answer specific questions about the latest outbreaks. And as Mr. Pollack said, it's not just measles that we're looking at right now, but a couple of different emergencies that are going on in the state. Representative Liebling.
Thank you, Mr. Chair. I think this is a really great idea, and I hope that it can go forward. I hope it can be funded, and particularly, as you say, that these things can arise when we're not in session, and we need to be able to meet these needs rather quickly sometimes. But the reason I raised my hand really is I just want to note that in the budget bill that, well, I don't know where we are right now, but I think that the budget bill that came out of the legislature also cut the Department of Health. And I just think that because we're dealing here, the Department of Health is often dealing with prevention. Prevention is never a sexy topic. It's just something that goes on behind the scenes. And, you know, that's kind of the major work of public health, is to keep these things from happening in the first place. So I think it's really important to have this response for when our prevention fails. But I think we also need to recognize that keeping the funding adequate for our really, I think, still nationally renowned Department of Health is important, so that we can be leading in that and prevent these things, even though none of us get credit for it when that happens. When we're just doing things the way we should, nobody gets credit for doing that. It just seems to happen. People think it's just the background. But in fact, it isn't. And in fact, the extension of lifespans and the fact that we kind of, most of us expect to be generally healthy and so on, and we have pretty long life expectancies, is due to public health work that kind of goes on in the background. So I just wanted to make that comment. I do hope we can move this forward, and appreciate that you're bringing this forward, Mr. Chair.
Mr. Chair, we think prevention is a sexy topic.
Representative Fisher.
Thank you, Mr. Chair. I had a couple of questions for the department. I'm not too sure who would be the best to answer it. It seems you folks are quite busy with all the exposures, et cetera, and some things I kind of like to have an idea on is on different diseases, you have different lengths of time that you track people for. And what I'd like to do is kind of get an idea with the different exposures, how in the different areas, how long do you have to track people for measles versus tuberculosis and syphilis, et cetera? What all goes into that type of situation?
Ms. Ayersman.
Chair Dean and Representative, you're right that the length of time that we track people does differ, and it has to do with the incubation period, the time between when someone's exposed and when they develop symptoms. So for instance, for measles, we use a 21-day window, and that's because we expect to see all the cases of measles that we're going to see from day 0 to day 21. And so that's why if we've had to ask children to stay out of childcare, it's for 21 days. With tuberculosis, on the other hand, it's a much different situation. In fact, St. Paul Ramsey County and the health department just conducted screenings last week, and we actually had to wait a certain 6 to 8 or 6 to 10 weeks, a certain length of time after exposures, so that we knew that people who might, develop a positive response to the testing that we would do had a chance to have that happen. And the follow-up that we'll need to be providing for the TB cases will be upwards of 2 years. And so that's a very different situation. So measles is explosive, if you will, and tuberculosis is really kind of a slow burn. And syphilis is kind of in between. I mean, you're not waiting, you don't have such a long time between when someone is exposed until they develop symptoms. But both between the tuberculosis and the measles, you get a sense of days to weeks and years.
Representative Fisher.
Thank you. You were mentioning that you have quite a few people working overtime and extra people working on these cases. Does that mean you're currently taking from other functions that the department is doing to address these issues?
Ms. Sears.
Chair Dean and Representative Fisher, yes, what we've had to do is we've had to divert staff from what we would consider to be our routine infectious disease work to focus them on what we consider to be sort of critical and crisis work. So yes, there's certain activities that aren't happening, certain grant requirements that we aren't meeting at this point.
Representative Fisher.
One of the questions I have is, as this kind of account is set up going future, does it address some of those that we don't lose some of the regular day work that is occurring, or does this just take care of like overtime and those kind of things that pop up to each individual situation?
Ms. Searsman.
Chair Dean and Representative Fisher, my understanding is that what this would allow us to do is we are not able to, add full-time equivalents, but what it allows us to do is definitely address issues of overtime, but also it allows us to use staff that we currently have on federal grants and then be able to back charge their time to the state fund so that the federal grant resources are there, and then we would have the ability to either hire temporary staff or ask CDC to extend the time to accomplish grant duties. But it would give us some options in terms of being nimble in our response and ensuring that we meet our federal grant obligations.
Thank you, Mr. Chair.
Representative Loeffler.
Thank you, Mr. Chair. And Ms. Ayersman, I was looking at the language that is the determination criteria, and I wondered if the use of the word large in a couple of the places, large number of deaths, serious injuries, long-term disabilities, some of those things, I'm wondering if significant or something like that. I'm thinking of like what I've read about the 1990 outbreak of measles, and there were 3 deaths. Now, I think 3 deaths is a lot of deaths amongst young children who otherwise were previously healthy, but I don't know if everyone would use that to describe large, as opposed to, the Black Plague that wiped out, 30-40% of the people, and so I'm just wondering if you would take some time at some point to just kind of once again review that to make sure that it would fit the kind of circumstances that we're talking about, because I think that's we don't want your hands tied when we think we've given you a tool and then someone challenges the interpretation.
Yeah.
And I know you have, an or in one place, but not on everything. And so I just want to make sure that you really carefully review that. The other thing that I've worried about, and it's not addressed in this bill, but I remember when the pandemic influenza was a threat and everybody was making provisions across the nation, including in our state laws, for quarantining people. And one of the issues was people who would lose their housing because they wouldn't get a paycheck, so they couldn't make their rent. And I think there was some hardship cases where you could provide some money to do that. And could you ever imagine needing authorization or something like this? I can imagine some of those children who are forbidden to go to childcare for 21 days. Their parents, many of them may work in low-wage situations where you don't get sick leave, you don't get paid leave. So mom has to go to work if it's a single household, and maybe providing some kind of benefit might make the difference between whether or not that child goes out of compliance and infects others, or whether or not that family potentially becomes homeless and then they end up in a shelter and you have another issue. And so I'm just wondering if you thought about those kind of things that might arise even in this type of an outbreak.
Ms. Searsman.
Chair Dean and Representative Loeffler, with your first question, we did interpret the ors as being, multiple ors, and so you could be, reasonably expected to require evacuation or possess the probability of a large number of deaths or widespread exposure, and so in that case, we felt that it offered flexibility. It is true that the definition of outbreak in the Dictionary of Epidemiology, which I'm sure you don't have on your shelves, but I do. But at any rate, the definition of outbreak is more than expected. But I think that this offers enough flexibility with the language that I think we're covered. And then to your question about providing assistance, that is something that has come up in our discussions, in particular with Hennepin County, who's had the majority of the cases. And I think that that's something that they were looking at, and I would think that if that became an expense, I don't know if that would be covered under this, because we can reimburse county health boards, but I'm not sure if that would be covered or not.
Well, thank you, Mr. Chair, and I think we need to think about that, because it's just, these things tend to unfortunately cluster in very low-income populations. I know of disease-resistant TB cases that have flourished in homeless populations, and, when they go into congregate living, shelters, mats on the floor, it's real easy to all of a sudden have something become much bigger, just because of the lack of adequate housing. And if you know someone's infected, that's one of the things you ought to ask is, do you have a home? Who's exposed in your home? And I'm sure you do. But for some of the transient populations we have, being able to make that rent payment is going to make the difference of whether they're in a shelter or whether they stay in that apartment that they told you they had.
Representative Pinto.
Thank you, Mr. Chair. I want to ask about the measles outbreak in particular. There was the proposal a couple of weeks ago now for an immunization grant program. And as I'm looking at this, that was on May 1st, and there were about 30, or maybe a few more than 30 cases at the time, at least that's what news reports say, and now we're up to 62. So it's 64, I guess, pardon me. Yeah, so basically doubled just in the couple weeks since that proposal. How would the, I guess first, can you just provide how's the response going in terms of support that the department's receiving and the funds available for that? And can you comment on the proposal for a grant program? I know one of the objections was that wouldn't have started until I think till July 1st. And just wanting to know, have you provide some comments on that proposal from just a couple weeks ago, since we've had a more than doubling of cases since then?
Ms. Earsman or Mr. Pollack.
Representative Pinto, or Mr. Chair, Representative Pinto, I believe the grant program you're talking about is Representative Omar's bill, the $500,000. The proposal that you have in front of you would not include grants to community organizations. That's really a prevention strategy versus the response activities that we're already engaging in for the current outbreaks. So they're really kind of two separate categories of activity for MDH, and the way this is written, that would not be included.
Representative Pinto.
Thank you, Mr. Chair. So, so if I'm understanding you right, then that the proposal would not be as focused on the response to this current outbreak. If I'm understanding what you're saying correctly, maybe I'm misunderstanding you.
Mr. Chair, Representative Pinto, no, this bill would respond to the current outbreak, but it wouldn't do the kind of prevention, education activities that were envisioned in that grant program, that proposal for a new grant to have community health workers and community organizations doing education in the Somali community, which was my understanding of what that proposal would do.
And Mr. Chair, so I guess, does the department, though, have a position? I remember another concern was the department hadn't expressed a position on that bill. Does the department have a position as to whether that proposal would be helpful in responding to this current outbreak that has doubled in the last couple of weeks?
Mr. Chair, Representative Pinto, no, we did not take a position on that bill at the time and have not today. Our focus right now is just getting the costs that we've already incurred to date for the response activities covered. We're certainly happy to talk about additional activities that could be funded with these dollars, but the bill language would have to be modified further.
Okay. Thank you, Mr. Chair.
Thank you. Other questions for the department? Representative Fisher.
Thank you, Mr. Chair. One of the questions that Representative Pinto brought up has triggered my mind an additional question, is you're mentioning that this does not apply to anything for preventive type work. How does that work in the type of situation, say if we had a pandemic flu outbreak that occurred and there was a special vaccine that they had to come out, would that mean that would not be covered and we'd have to look at how to address that kind of situation?
Ms. Earsman.
Chair Dean and Representative Fisher, I think that would be a bit of a different situation, and I'm quite sure that if we had the need, if we had identified that there was a lack of availability, for instance, for MMR vaccine, or people are having difficulty accessing the vaccine, that we would be able to use these funds as part of that response. But I think that what Representative Pinto was talking about, and Assistant Commissioner Pollack, is that the idea for the outreach would be a much sort of different approach. So it wouldn't be mass vaccination just to respond to measles. It would actually involve, a lot of community outreach, working with partners, that type of thing. So it has a little bit different flavor. So I wouldn't want to give the impression that we don't do some level of prevention during our response, but that just had a much more long-term perspective than I think we're looking at with this potential legislation.
Representative Fisher.
Thank you, Mr. Chair, and thank you for that clarification, because I know that while we're kind of focused on the measles and the tuberculosis and syphilis right now, we're also taking a look at other things that may happen down the road, and I want to make sure that we're keeping those other things in mind. So I appreciate hearing that response and understanding that there will be ways to address that type of situation. So thank you for that clarification.
All right. Just Representative Murphy.
Thanks, Mr. Chair. And I'm just wondering if the folks from the Department of Health can give us any sort of update without violating confidentiality about the status of the folks with measles.
Chair Dean and Representative Murphy. Yes, I mean, we've had 16 of the 64 cases have been hospitalized. And usually the complications that they experience that require hospitalization include dehydration and pneumonia. So we've seen a number of cases of pneumonia, secondary pneumonias. There is one child who's been hospitalized for more than 3 weeks because of their pneumonia. So that, if that is what you're looking for, to give you a sense of what we're seeing. So we feel that this is, a severe disease, and that we've had, 28% of the cases hospitalized.
And Mr. Chair,
Representative Murphy.
thanks. And what is the course of treatment for congenital syphilis?
Ms. Harris.
Chair Dean and Representative Murphy, there really isn't a treatment. It would be supportive care. If a woman is pregnant and gets syphilis and then is treated for syphilis during her pregnancy, that can prevent congenital syphilis. So as a result of the current outbreak, the Department of Health has made the recommendation that women should be screened 3 different times during their pregnancies, which is 1 time more than the usual recommendation because of what we're seeing. And so that the goal of that would be that women would be identified early and get on treatment, and then we could prevent congenital syphilis, because once a child has congenital syphilis, you're providing supportive care.
Okay.
Representative Johnson.
Mr. Chair, don't have really a question, but more of a comment. I'm actually hoping that we could go forward with this idea this year, because I think it's that important, because this bill gives the agency the ability to respond to events that could occur at any time, gives them the flexibility to do the jobs they need to do in these outbreaks. So I'm glad you're bringing this forward.
Representative Zerwas.
Thank you, Mr. Chair. And I'm just wondering if we can talk a little bit. I saw there was a media report that talked about some of the daycare centers and the fact that MDH was having trouble with I believe just one of the daycare centers being not cooperative and working with the department, and some of the recommendations or requests that the department had. I wonder if you can kind of take us through what the daycare center involvement was, how the department responds to a scenario like that, what some of those requests or recommendations are, and then the instance where the daycare center apparently, or at least reportedly, was either non-responsive or non-cooperative.
Ms. Harrisman.
Chair Dean and Representative Zerwas. Yes, we have had 11 daycare centers that have had exposures, and 10 of those centers have been wonderfully cooperative. We did have one center where we had difficulty. We tried to work with them for 2 weeks to try and get the information that we needed. And what we need from child care centers is, if we have a case in their center, we need to get a list of all the children that attend, as well as their vaccination status. And that way we can look and see who's susceptible, who's in attendance, that type, and who was potentially exposed, so we can look at when the original case was at childcare and what children were, sharing airspace with them. And what we were having difficulty with this particular childcare center was getting complete lists. And so they gave us a partial roster, with maybe 40 kids on it, and then we knew that it wasn't complete because some of the kids that we knew that had measles that had attended the center weren't on the list, and multiple phone calls, visits with our Somali staff. I felt that our staff had really done a great job of reaching out to the center. And when we weren't getting the cooperation that we needed, and we really feared that we were going to, this was going to extend the outbreak unnecessarily, we had been working with the Department of Human Services all along on this outbreak. And so we worked with them, and they issued a temporary suspension for the center, so they temporarily suspended their license, and that license was suspended on last Thursday afternoon. They're back today. They're back in business today, and so really their license was suspended until we had time to get records from them, check those records, identify who was at risk, that type of thing. And so we felt that it worked well to work with DHS. They were exceptionally helpful to us, and we felt that it was the sort of the best case scenario. There were certainly sanctions. We felt that because this center was not cooperative, but all the others were, it wasn't fair to them. That this center wasn't doing the right thing. And so by suspending their license for 5 days, I think it got the message across. We got the information that we needed, and they're back serving their clients now.
Mr. Chair, thank you for kind of the background information. So when you get a report that they're, for like a licensed daycare center, there's been a report of a child that's been there that now has a serious infectious disease like measles, is there something that either the Department of Health or Department of Human Services does to notify the other families or attendees? Is there a posting, or is there a letter that's sent out? I guess one of my concerns is, while the days intervene where you're getting incomplete lists or not all the information, are there families that are perhaps continuing to bring their children there that don't know that there's been reported active cases of the measles at this daycare facility, either because we haven't been able to notify them, or that it isn't our protocol to notify all the families, or kind of what does that part of it look like?
Ms. Harrisman.
Chair Dean and Representative Zerwas, yes, when we got the incomplete list, we worked with that list and notified the people that we had, but then we went back to them and asked for more, and we continued to try and get information from them. But you're right, until we have complete information, we're unable to make a complete notification, and that's why we felt that it was necessary to work with our partner, the Department of Human Services to take action.
And I guess just a final comment, I guess, as hopefully as this outbreak, reaches its peak and things calm down, we work into the summer, and you kind of look back and kind of debrief the scenario, I think there's an opportunity to see if there's any tools through further legislation that we need to provide either the Department of Health or the Department of Human Services to go through that process in a more expeditious fashion. Because I have a really big concern of the idea of unsuspecting parents that are continuing to, drop their child off per usual, and perhaps not aware that not only has there been a case of the measles, but there's active cases of the measles, and that daycare center, that day continued to be not responsive or not cooperative with the Department of Health in trying to stem that outbreak. I think if parents were aware of that information, my guess is their census would have dropped pretty dramatically. And so I'm wondering, as we kind of look at the debrief of all this, if there's a way to kind of report back, whether it's to Chair Dean or the ranking minority member as well, just if there's a process that could be tightened there for family protections around people that, you're bringing your child to a licensed daycare facility, you assume that we're doing everything we can, and it just makes me nervous when there's gaps like that.
All right, Representative Schultz.
Thank you, Mr. Chair. So what are hospitals doing right now to make sure that they're limiting transmissions within the hospital? And does MDH work with the hospitals on policy?
Mr. Earsman.
Chair Dean and Representative Schultz, yes, we are working with hospitals. And there's a couple of things that are happening in the hospital and healthcare setting. As you may have heard in the news, there are several health systems that have actually restricted visitors to their facilities in an attempt to minimize the potential for exposure to at-risk and immunocompromised patients. But when we have an exposure in a healthcare setting, we work with that facility to kind of talk them through the steps of how they need to respond. And that includes identifying all the patients who may have been exposed. And that's why when we talk about the workload, it's quite extensive. We go through the exposure situation with them, who may have been exposed, what patients, what was their immunization status, that type of thing. The healthcare settings will oftentimes then, they'll contact these individuals. They will offer what's called post-exposure prophylaxis, which means that if they can get either vaccine or immune globulin, depending on the individual status, into a person, that can sometimes help to mitigate measles and prevent it from happening. So that's something that they're working on. We also have worked with them on just general procedures for taking care of patients with measles. A lot of facilities now have greeters that meet patients when they come in the door, mask them immediately, all in the attempt to minimize the potential for exposure, because measles is transmitted via the respiratory route. We have a team, so we have a structure that includes the epidemiologists and the people that are working with schools and daycare, and we have a team that just works with healthcare facilities. We have a weekly call with the infection preventionists to go over any concerns they might have, and we just had it today. So we're very involved in working with healthcare facilities in terms of both one-on-one when they have an exposure, and then more broadly to address questions they might have related to measles.
Thank you. Mr. Chair, and how many members of your organization of MDH are working on this right now, and how many have had to be pulled from other areas to work on this outbreak of measles?
Mr. Earsman.
Chair Dean and Representative Schultz, we have about 70 people that are currently working on measles, and that includes our laboratory staff. And obviously we can't switch out those staff, but we do have staff who have come from our healthcare associated infections area. We have staff that have come from our emerging infections, from foodborne. We really have pulled staff from just about every area within the division, with the exception of tuberculosis and STDs, because they're busy working on their own situation.
Thank you. One more question, Mr. Chair.
Representative Schultz.
Thank you, Mr. Chair. And I'm concerned that this number has doubled in the last few weeks. And is there a number where you get really concerned that it could take, off exponentially? Is there a threshold where you become even more concerned and need to pull more staff in on addressing it, the outbreak?
Ms. Earsman.
Chair Dean and Representative Schultz, Well, I would say that we're definitely concerned at 64 cases. As we've talked about, this is, many more cases than we've seen in the last 27 years. In 1990, when we had the large outbreak, I was a graduate student worker at the department. So this is the biggest outbreak I've seen in my career since that time. And in terms of, is there a number that really concerns us? I think that what we worry about is that we don't know which case will have the underlying health conditions that may result in a death or may result in a very serious situation. And any time that you're adding to the number of cases, you're just adding the probability that could happen. But what we do have that's an advantage is as you get your system ready to go and to respond, you become more efficient in your response. And so I would say that as cases are going up, our efficiency is increasing as well. And so, I think that we're in a good place right now in terms of our ability to respond. But I am concerned that this is going to go on for many more weeks. And that does concern me just because of people just getting exhausted.
And is it because also compared to 1990, we have more people that are not vaccinated?
Sorry. Well, it's actually, no, what happened in 1990, that outbreak was really caused by unvaccinated preschool children, but that outbreak was really driven by issues of access to care. And there's a Vaccines for Children program that was initiated at the federal level in 1993, and that has really addressed disparities in immunization based on access to care. And what we're seeing with this outbreak is really an outbreak that's driven by individuals choosing not to be vaccinated. And I think in the case of the Somali community, based on misinformation. And when you get those pockets, those clusters of unvaccinated individuals, it allows outbreaks to really take hold and spread.
Thank you.
All right. Next up, we're going to have Lorna Schmidt, the Executive Director of Local Public Health Association. Thanks, Department. Welcome to the committee. Please introduce yourself for the record and proceed.
Thank you, Mr. Chair and members of the committee. My name is Lorna Schmidt. Again, I'm the Director of the Local Public Health Association of Minnesota, here today on behalf of local public health departments across all 87 counties, as well as some tribal nations. And I am aware I may be the last thing between you and home right now, so I will be brief. We appreciate the increased attention that's being given to local public health funding in light of the current measles outbreak, which has put additional stress on an already stressed system. Local public health departments are statutorily mandated to prevent the spread of infectious diseases. Even in counties where measles cases haven't yet been confirmed, local departments are spending significant time and resources working with community partners to raise awareness of the importance of vaccines and be prepared to respond quickly if or when a case occurs. These additional expenses often fall on local tax levies, which already make up the single largest source of funding for local public health. The proposal before you would provide critical funding to augment outbreak response efforts in the short term. It would not, however, diminish the need for a longer-term statewide investment in our public health system. Many outbreaks, like measles, are preventable, and measles isn't the only priority demanding a public health response right now. An increase in syphilis cases, an opioid abuse epidemic, more children suspected of being abused, tuberculosis outbreaks, a growing mental health crisis, and concerns of drinking water safety. What we really are seeing are the symptoms of an eroding public health system. We are not opposed to the concept of a contingency account, but we encourage you to consider increasing the state's investment in the local public health grant as a necessary and more sustainable mechanism to protect and promote the public health. The local public health grant is the state's main investment in our local public health system and the core functions of government mandated to it by state statute. Its flexibility means that local governments could put dollars towards emergency efforts, like those currently required for measles. They could also put it towards other mandates and community needs, including but not limited to opioids, mental health, and many of the others that were already mentioned this evening. Local public health grant funds go to all community health boards and tribes, ensuring statewide reach. But current funding is insufficient, and it has significantly compromised local public health's capacity to effectively carry out its statutorily mandated services, preventing the spread of infectious disease being just one of them. A public health contingency fund will provide a boost to some response efforts, But without greater long-term statewide investment in the local public health grant, capacity for prevention and response will continue to lag further behind, and the health and safety of our communities will continue to be put at risk. We appreciate your attention, and I'd be happy to answer any questions.
Thank you, Ms. Schmidt. Representative Franson.
Thank you, Mr. Chair. And to the testifier, talking about outreach, are we, does that also include like dietary, because vitamin A deficiency, vitamin D deficiency?
I'd say sorry, Mr. Chair, Representative, I would say in general, yes, those are issues that public health nurses and other health educators would be working on with families and others in need.
Thank you. Other questions? All right. Thank you for your testimony today, and thank you for coming back. Sorry to make you come back this evening. Appreciate your time and your testimony. Anybody else would like to testify on this topic or the bill or amendment? All right. Seeing none, appreciate everybody coming back. If I could make one request of the department, specific to the Somali community for outreach in vaccination awareness and information. If you could just maybe provide the committee a very brief wrap up of what you're currently doing, very specific to the Somali community in outreach around vaccinations and also around measles in particular. But whatever we're doing specifically for the disparity in the Somali community because of the choice to not vaccinate within the last year, just so we can kind of get a picture of how much communication has been out there within existing grants and where we need to go from there. Representative Murphy.
Thanks, Mr. Chair. And I'm just, I talked yesterday briefly about this, so we're just a few days from being done, and there's a big negotiation going on. If there was room for this in Health and Human Services before the end of the session, would we do an official hearing on it? Would it go to the Rules Committee? Do you have a sense of the path for this if we were going to actually act on it this session?
What it would likely do would be to appear the most likely path would be a conference committee report to have it within the conference committee. If we had an open conference committee, that would be the best way to get this paid for this year.
Okay. And Mr. Chair, there was Representative Loeffler was talking a little bit about the determination, the criteria, and the testimony was really about an interpretation of that language. So I guess maybe we should talk offline just to make sure that it's clear from your perspective, so that we don't send something that's ambiguous forward.
Yeah, if everybody, I think, could take a look at the language. Obviously, we only got a couple days, so we're going to be acting on this really quickly if we are able to act on it before the end of session, and I hope that we do and we can be out of here on time. So for that to happen, we obviously need that to reappear in a bill. Other questions? All right, seeing none, thanks for coming back, everybody. Sorry to delay the day, but I think it was an important discussion. Look forward to seeing you tomorrow. Adjourned.